You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Steven Feldman, editor of the Journal of Dermatological Treatment and professor of dermatology at the Wake Forest University School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Steven Feldman. Welcome to Medscape's In Discussion series on psoriasis. Thanks for joining us for the 5th episode of our 4th season. Artificial intelligence is beginning to reshape medicine. Today, we're looking at where AI is already making a difference, where the hype outpaces the evidence, and what this means for clinicians managing psoriasis in the real world. Our guest is a board-certified dermatologist and chair of the dermatology department at the Palo Alto Medical Foundation, as well as chair of the San Francisco Dermatological Society, one of the oldest dermatology societies in the country. Our guest's perspective is unique. She holds a degree in biotech from UC Davis, completed a clinical research postgraduate fellowship at Stanford, trained in psoriasis immunotherapy at UCSF. This is a rare combination of engineering, research, and clinical expertise. She is also the founder of DermGPT. This is an AI tool built specifically to support dermatologists with clinical tests and practice productivity. And she's the founder of SoTelehealth.com. That's PSO telehealth.com, a telehealth platform dedicated to psoriasis care. And our guest is also the host of the Future of Dermatology podcast, which I highly recommend. It's my pleasure to introduce Dr. Faranak Kamangar. Welcome to In Discussion.
Thank you so much, Dr. Feldman. Thank you for having me.
Before dermatology residency, you did research with one of the most eminent psoriasis experts of them all, Dr. John Koo at the University of California, San Francisco. He helped shape how an entire generation of dermatologists think about psoriasis treatment. And so I was wondering, you've gotten so into AI. Was it John's legendary expertise with computers and technology that got you interested in this area?
Absolutely. Yes, that is a great place to start. Working with Dr. Koo, and we still, all of his fellows and everyone who has worked with him, we still constantly bother him with questions. So he doesn't get rid of his fellow network ever. But that is hilarious about his tech abilities, because he himself jokingly will say, I won't even check my email. I don't want to turn on a laptop. I think there was a day when he got maybe the iPhone and started texting us. Everybody texted each other around the country. We're like, oh my gosh, Dr. Koo's on the iPhone.
Are you sure it wasn't his wife texting for
But
him?
we still don't know. We still haven't verified. We don't have a photo of him, on the phone. He is fantastic. But the funny thing is, about maybe 2 or 3 years ago at SF Derm, we held an AI panel, and I asked Dr. Koo if he would be on the panel, and he was like, "Sure. I don't really know anything about, AI or computers, but I will absolutely join." And the things that he said were so pertinent and amazing, and it just kind of shows in the time of AI, it's not necessarily the technical abilities anymore. It really is the importance of the domain expert and how they build out the architecture or technology of how the AI can be built. Because there's so many tools that could build it for us now. And he was fantastic on that panel. So that is a great start to kind of combining exact expertise and technology.
Outstanding. So let's talk about some of the ways AI is going to play a role in medicine. We could start with, I think, diagnosis. I like things in order: diagnosis, treatment, efficiency.
Mhm.
But maybe there's something else I'm missing. Should we start with diagnosis or patient education? What do you think?
Yes, yeah, I think diagnosis is a great place to start, and there are a ton of projects going on around using visual, because we're a visual field in dermatology. So, of course, when it goes into diagnosis, everybody tried to build these machine learning platforms to diagnose, basically do what we can do visually, have these machines do that for us and diagnose patterns and diseases. Psoriasis specifically has had a lot of actual development in this space, and the AI models are pretty good at differentiating different papillosquamous diseases. And again, that might not be the hardest diagnosis for a dermatologist, but there are so many people in the world that have psoriasis and don't have access to a dermatologist. So I think there's huge implications for just health equity, democratizing, what we do. So there's a lot of headway in that space of maybe primary care or non-dermatologist actually diagnosing it correctly. Then there's all the tools. And with Dr. Koo, we used to do all the POSI scores. I don't even know if I could do a POSI score right now if I had to off the top of my head, but we were doing them all the time. AI can just do that now. Like skills like that, it's so good. There's a higher level things too, like for the dermatologist, with all of the advancements in the basic science, the genomics, being able to actually predict what medication might fit someone, like being able to diagnose on that higher level. If we know which cohort will go on to develop psoriatic arthritis or not, like those will be really helpful questions for us to kind of add to our diagnostic armamentarium too. So AI is just pushing all of that forward.
Yeah, I get the sense you sound inappropriately optimistic that AI will be used to complement us and not replace us.
Yeah, yeah, absolutely. It still won't replace us. I think that, the good thing is there's not that many of us, so you really can't replace us that easily. And then AI, more than anything, will probably replace some elements and some human beings in the chain, but it won't replace the domain experts. Actually, if anything, it highlights the role of the domain expert. And I think, when it comes to psoriasis and skin, the board certified derms have probably spent a crazy amount of time building that expertise. So I think we're pretty safe.
I get the sense that AI could potentially be more objective than we are about measuring disease severity. I had the sense that when you're enrolling people in trials, and you've probably done that, and they have a borderline POSI score for getting in, then you're able to, well, I think
Right.
it's a 3, not a 2. I wouldn't lie, but it could be either one. We'll go with the 3. And then their score is higher than it would be otherwise. Whereas an AI would be, hey, this is what it is. I don't care how much money I'm going to make for enrolling this subject.
Totally, because there's so much kind of that non-standardized work. As much as we try to standardize protocols, there's still that human being element of, well, maybe it's this, maybe it's that. So yeah, I think just standardizing trials will be really great too. That'll be kind of a good thing. Like we really know things are done under one protocol.
So, how good today are the AI models for diagnosis? If a patient has a rash, they take a picture of it, they upload it to a Google image search or some medical site. How likely is it the AI is going to give them a correct answer?
It's actually pretty good now. So again, it all depends on the photography and the lighting and all of these and what the patient says in the prompt. It's interesting when it's done in like a clinical trial or paper that residents are writing up and they do it in a very controlled format, the AI does really well. When it's patients just submitting on their own, they're not asking the right questions. So there's a lot of data that when it's just a patient and a model, they actually get worse outcomes or they get weird answers coming back. So that scenario by itself so far is not the full therapeutic journey. But if we're just looking at how good is a model and we get rid of the variables like the photos are standardized or good quality, we prompt it correctly, they're pretty high accuracy at being able to diagnose something like psoriasis. With the POSI scores, they're really good with that too, just being able to outline differentiation of, and again, with skin color, that gets a little bit harder because you do that differentiation of color. The thickness AI might still have trouble with, kind of like the scale or thickness levels is still that something that they can't perceive, as well. But I think over time, there's more 3D model imaging models and things coming out. So those are all probably fixable.
How about a skin lesion? If a patient has some changed mole or they put a picture of a seb or a melanoma in, how accurate is that?
The FDA approved models that are out there, still not as accurate as us. There are these papers that come out with like a very specific task and they say, oh, it beat the dermatologist. But if you kind of look at the sensitivity and specificity of how good we are, the models out there are just picking up a lot of negatives basically too. So like if you were to biopsy everything an AI model picked up, you would be doing a ton of excess biopsies that are not necessary. So they're kind of set to pick up more than miss. So in that way, sometimes they look like they are actually, they're not missing any melanomas. The problem is in real world, they're just picking up a bunch of benign spots. So it's not really useful.
Yeah.
So the
So,
dermatologist is still a little bit better at that. But what they can do better than us is that overtime monitoring. So that chronological monitoring of a mole. Like there's no way I'll remember what that looked like 6 months ago. Even if I look at the photo that we take on our little iPad in clinic, it's not going to be perfect, but like a dermoscopic standardized photo, AI is really good at detecting change better than we can do.
How about the non-FDA models? If I just take a picture of a SEB or a nevus or a melanoma and throw it into a Google image search, or ask my friend, my really good friend, my best friend Claude, hey Claude, what is this? Is it going to know what the thing is?
It's really good now. The models are very, very good. Even on Derm GPT, we have an image capture, and we don't want it used for that purpose of AI diagnostics, but they're really good. The foundational models are actually scary, good on how effective they are. And they're pretty much have access to a lot of the data sets that these kind of specific projects are doing too. So there's kind of not a whole lot of difference between just the general foundation models and some of these like, really specific projects that people are spending a lot of time on. But again, it's all about kind of how you prompt. So there's that whole environment as well of, how you engage with an LLM as well. But they're good. They're highly diagnostic, I would say.
So let's finish up diagnosis, but just asking specifically about Derm GPT and how you envision its best ways of being used diagnostically.
So it's a large language model. We do have image upload as well. So someone can put an image and ask, hey, what is this? And, continue asking questions. It's actually also pretty good about, pattern recognition there. But really our main purpose is to try to use it for just the text-based tasks. I think that's probably the most ready to use task in clinic right now is all the hours of work we have to do on top of our patient facing time. I think that's like the lowest hanging fruit right now for us to just turn like 3 hours into 20 minutes. That's what we really want to do with the large language models, which they can do text-based work really, really well. There's really not a whole lot of error in text-based work.
And so I imagine the treatment is heavily text-based work. What do I do for this disease?
Yes, yep, exactly. So like guidelines, patient handouts, targeting a patient handout to be perfect for the patient in front of you, because we all have the generic handouts that everybody kind of throws away after the doctor's office. But if you're able to change literacy level, sometimes even what language it's in, change it to the exact modality that the patient's going to be doing the treatment, very like real world kind of handouts, they're highly effective. So the educational tools are effective. Giving information about treatment options is pretty easy to do. Like you can go in a large language model and say, write me a chart between these three biologics, and these are the specific context for this patient, and write them in that regard. And then that patient can maybe take a look at that and choose, versus before we would kind of maybe give them three generic pamphlets and they'd have to go home and Google and kind of try to decide. In the end, we'd write a prescription and the insurance tells us what to write anyway. But in theory, there's a lot of education around what treatments we use. And the AI isn't quite there yet. But when the genomics and all of that, it's getting a lot better. We might be able to predict who will do better on what treatment. So sometimes we're just kind of guessing on what first treatment to start. And then we know there's a good amount of patients do well. Many fail a second biologic, a third biologic. So a lot more information, for the patient and for the physician coming.
You're making me think that GPT and these similar models are like having a little group at your ready that includes a medical content expert, a teacher, a therapist, and a medical librarian, like all combined into one.
Absolutely. Yep. The whole thing is to just 10x every role in the office, add roles that are not even in the office, skill sets that are not always in the office with you, but you 10x the physician, 10x your medical assistant, 10x the nurses. Production wise, you can increase everyone's work, but also you can bring in all these new skill sets that didn't exist.
Let's talk about some of those efficiencies. We like to be efficient. What are some of the top ways of using GPT or other AIs to improve office efficiency?
In clinic, we have a lot of extra work that we do. And for every 8 hours of patient facing time, we'll spend 5 hours on electronic health records. Recently, I looked at my data for the last 10 years as I'm switching practice models, and I noticed about over 80% of my encounters were not patient facing. I had 20% patient facing encounters. Everything else was the in basket messages, telephone encounters, messages you're getting from pharmacy for prior auths. So all that extra stuff that's text-based, AI can intervene. The first place I think is the note. If we can make your note pretty good, that's a good place to start because the rest of the team can work off of that. The one place I would say for everyone to do if they're not optimizing, just even ask an LLM. I'm writing this medication for this indication. How can I optimize my note for prior auth approval? All of that. So you're just putting in things that are easy. Sometimes there's easy misses. If it's not in the note, the prior auth will get rejected. So maximizing the note is like the first place to go. And then from that, you can apply AI to answer patient questions that come after that. I always also advise having almost like a FAQ, like frequently asked questions in the handouts, because a lot of the messages that come in, patients don't want to be messaging you either. They just want to get like a quick answer. And a lot of companies do this. They have like FAQ customer service rings just to decrease the amount of calls and inquiries coming in. So those are easy things you can literally say, come up with the top 10 things you think my patient might ask, and answer them here and give that to the patient before they leave the office. So if you even just decrease your prior auth denial rates by a certain percent, decrease your in-basket messages coming in by a certain percent, you're already cutting down minutes without doing anything too extra fancy.
I thought since my iPhone sees better than I do and has better memory than I do, that it would replace me, except for the fact that patients want an empathetic, caring doctor. And then I saw what I believe was a Stanford study that showed that AI's responses to patients were more empathetic than those of actual physicians.
Yeah, actually, that's because AI is made to sound really good. Like our messages, if I message back a patient, it's going to be hurried, it's going to be fast. I'm going to try to get some facts across. AI is meant to actually be like very pleasing language. It wants you to keep engaging with it, like especially the foundational models are built on the time you spend on the LLM. So they want to be very nice and cordial. So the conversation keeps going. So I'm not surprised at all that it beats us in the empathy department, just because it has more time and its task is there to spend all the time in the world, be as nice as you can. If you notice, AI doesn't really say a lot of mean things to you. Like it's always like, you're right, you're great. That was a great thought. So
Yeah, but you can change the settings on it to say, listen, don't flatter me. I want you to be honest.
you can absolutely prompt it to say that. But again, there is such hard coded master prompts that the foundational models have. As much as you prompt yourself, it'll always to some degree revert back to what it's kind of made to do. We made Derm GPT to be a little mean. We said, if you don't have an answer, just don't say anything. And the different LLMs all have a different vibe. And it's kind of what philosophies the group thought are important, what guardrails are important to keep.
I understand you're getting ready to open a private practice, perhaps later this year, and that must be exciting. I don't know how you have time to do all these things. Aside from the things you've already mentioned, were there any other ways you're going to be incorporating AI into your practice?
Yes, yeah. So this was everyone's kind of laughing at me because like no one goes to private practice anymore. Like this makes no sense, which is true for the most part. And I'm coming from a really great multi-specialty center at PAMF, and I've been there over 10 years. So it doesn't quite make sense, in that sense. But for me, the reason is really the AI and the innovation. It's hard to add these layers on top of existing technology. A lot of the medical centers are trying to do it, but there's a lot of friction with just existing technologies that are huge, and you're trying to layer something on top of a technology that wasn't made for it. With the practice, I'm really building an AI up practice. So every move we're making, every technology we're adding is to incorporate every journey of AI in the practice. So if all works well, we don't have that extra 5 hours after we see patients, but then also we can include all these extra things for the patients to monitor themselves at home, do the surveys at home on their own. So it's kind of exciting to see what you can build when you have a blank slate.
I stopped at Taco Bell the other day on my way home from a trip, and I'm pretty sure it wasn't a human taking my order. I wonder if you'll have an AI robot check people in.
Yeah, it's funny. There's so many entry points of AI into practice. I still really feel like the human parts needs to be more human. And I've heard from colleagues that have brought on the technology where the AI answers the phone and all of that. That hasn't been super successful. So I think we still need to be kind of choosy. I think it's great in the back end making us more productive. I don't think people are really ready for it on the front end. Me too. Like I called a restaurant and I could tell it was AI, and I hung up and went to a different different restaurant. I don't think we're necessarily all ready, and we don't want to lose that part. What we want is for us to have more time to kind of do the human parts.
All right. Well, today we talked to Dr. Kamangar about using AI in the detection and treatment of psoriasis. These AIs can see. They got great memory. They know so much, and they can still make mistakes. But then again, so can I. I think AI will replace us. Maybe not this week. Maybe it'll be next week. But fortunately, Farah, our expert, says, nope, the clinician will stay in the loop. That's good news, but we'll see. Thanks so much for joining us. This is Dr. Steve Feldman for In Discussion.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Steven R. Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on psoriasis.